What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? It's Dr. Zach Baker here on the Strength and Knowledge Podcast with your sports resident, Dr. Bami Adu of Rehab to Perform. And Bami is down at our Germantown location doing his clinical hours, and then he meets up with myself and our other sports resident, Christian Huckfelt, at our Mount Airy location every Thursday to go through more of our classroom educational time. And part of that time is that we do a monthly journal article review that then gets presented to the entire R2P staff. So our residents go through and find an article that's consistent with whatever the monthly theme of our residency material is, find one that meets a patient population that we see at R2P, and then they go through that article, figure out what's meaningful, what's relevant, and how's it really going to resonate with what we do within the PT field, and notably at our clinic. So this month happened to be the foot and ankle. And Bami, do you mind just talking a little bit about the article that you selected?
Yeah, sure. So the article I selected was muscle activations during functional tasks in individuals with chronic ankle instability, a systematic review of EMG studies. So I chose this article because, we see a lot of youth athletes, and chronic ankle instability are very dominant in the youth athletes, and it's even pretty prevalent when you look at your general population, even your older age population individuals. So this article does a really good job at telling us the different types of muscle activation, which muscles are being used, and which muscles aren't being used as much, and it kind of clues us in as physical therapists of what we want to do from an intervention standpoint.
Definitely. And I think ankle sprains tend to be the injury within our field that often get overlooked. And I think part of that has to do with just how common they are. And I think if any of you have played a sport or really just been active in your lifetime, you've probably rolled an ankle. And more often than not, you probably did not seek formal care for it. If you were able to keep moving around and keep walking on it, it may have swelled up on you. It may have gotten a little bruised. But you probably just modified activity for a little bit and tried to get back out onto the field or the court as soon as possible. And I think we all know how that goes. There's definitely a transitional period where we feel like we are definitely not operating at 100%. And I think, unfortunately, sometimes we don't actually always get back to 100%, and that may be noticeable with our performance. It may be noticeable from a tolerance standpoint. And I think sometimes there's just some underlying things going on that we may not even be aware of that are influencing how well we're able to tolerate or perform an activity. So I think we're starting to see really in the last 5 to 10 years within our field that chronic ankle instability and recurrent ankle sprains, there's more to them than what we thought, and I think we need to make a very concentrated and intentional effort when we have these individuals diagnosed and coming in, one, encouraging them to seek care for the ankle sprain, but then also figuring out how are we best handling this and making sure that we're setting them up for success in the short term and the long term. So, Bami, within this article, what was the patient population that they looked at, or what were they actually dealing with just from a patient demographic standpoint?
Yeah, so this article was a systematic review, so they didn't really specify the patient population and gender, which is something I felt was a limitation. But they're able to get 63 articles, and the way they assessed the quality of the articles, they had something called a Downs and Black checklist. So they had a checklist for an answer of yes, no, or unable to determine. 1 point was given for each answer, and then they used this as a quality to assess. So the percentage, 60% or less, was a low quality article. A moderate quality article was 60 to 74%, and a high quality was anything greater than 75%. So based off this checklist that they had, they were able to get 38 of 63 studies, which were moderate quality, 24 or 63 were high quality, and only one study was a low quality study. So with that being said, all the studies had to meet an inclusion criteria that they had. So all the studies had to have been published between December of 2000 and December of 2020. The participants in the study had to have chronic functional ankle instability. They had to have a performance of any kind of functional task or responsive perturbations in the study. The study had to describe amplitude or timing of onset or duration of muscle activation of the muscles, and they had to have a presence of a control group described as healthy participants.
So we've got a lot of articles that they comb through over a 20-year time frame, it looks like. So a good bit of data to go through, a wide variety of measures that they were looking at from an inclusion standpoint. With the article, though, what were they actually measuring as outcomes? What were they hoping to find? What were they utilizing as just different objective checkpoints with this?
Yeah, so the article was looking at a bunch of different endpoints. I'm going to talk very briefly about the ones I think it's most prevalent in our practice. So one thing they looked at was muscle activation during gait. And what they ended up finding with that was that the peroneus longus activation was higher, longer, and it was earlier during walking. So this could be due to people compensating, not wanting to trying to avoid that inversions. Another thing they found was muscle activation in response to ankle perturbations or postural perturbations. So what they found in this endpoint was that the studies investigating the latency of muscle activations in response to inversion perturbations, they found a longer reaction time of the peroneus longus compared to controls. And to even go further, they found that proximal muscles activated before the distal muscles in response to trunk perturbation. So this is kind of showing us that patients with this ankle instability, they're using more of their hip and spine to strategy in order to kind of keep them from falling down, and they're not really tapping into their ankle muscles. Again, it's another compensatory strategy that they're using.
Good, and I like that it pointed out really latency in regards to timing of how they're doing this. And then also, what is their actual strategy? And I think the timing may not be something that we can just pick up with our naked eye when we are in the clinic. And we're probably more concerned when we're doing our different functional assessments of, can they complete the task or not? Maybe we're doing a balance assessment. Do they fall or do they not fall? Well, that's a pretty wide range that errors could be happening. And we're using just very dichotomous, did it occur, did it not occur? But the actual mechanisms happening underneath, unless we dive a little bit deeper, we're not sure of what's going on. So I think that's often something that goes overlooked, and I'm glad that these studies pick up on that. And then the next part of that is it's not just the ankle and the foot and ankle complex that we're worried about, because if there are deficiencies there, we're going to have to try to hide those deficiencies elsewhere. And I think that's where, with chronic ankle instability, where we're setting ourselves up for potential failure returning these athletes is maybe their foot and ankle isn't going to be the next thing that they re-aggravate or re-injure, but maybe this is leading to an ACL injury or a hip injury or something else along those lines. Bami, what were they able to actually find when they went through the results with these studies?
Yeah, Zach, just to go off that point, it's that's the cool thing about EMG studies is that it's really tough to the naked eye to see the compensatory mechanism they're using. So the EMG studies gives you a good idea of what muscles are actually firing and what muscles aren't firing or when they are firing. But to go off your answer, so ultimately what they really found in the study was that individuals with ankle instability have delayed activation of the peroneus longus in response to sudden inversion perturbations. They also found that same finding in when people transition from a double to single limb stance and when people are kicking a ball and when they're kind of landing on an unstable surface. They found that hip and spine muscles were activated before ankle muscles in patients with ankle instability compared to the controls. They found that the peroneus longus and the tibialis anterior muscles have an abnormal activation in ankle instability individuals. And lastly, they found that when it comes to a balanced task, that these individuals are using more of a proximal muscle strategy rather than their ankles.
Now, we could talk for hours on this next topic, but I like how you mentioned EMG studies are cool because it lets you know what's happening and what is not happening. Unfortunately, if you're playing basketball, if you're playing soccer, if you're playing football, when you go to make a cut, when you go to kick a ball, when you go to change direction, we're not actively thinking, oh, am I using my hip or am I using my ankle? Am I using my gastroc or am I using my peroneal muscles? What's actually happening? A lot of that should happen involuntarily. It should happen just automatically. What are some big take-home messages from this article? If we know these are some of the changes that happen, one, how can we identify them in the clinic just from an evaluation standpoint? And then if we do identify them as being present, meaning they have this latency and reaction time, they have these altered writing strategies for balance writing, what can we actually do from an intervention strategy? And I think that's where a lot of us get hung up, and I know personally coming out of school, I would get stuck on one of two ends of the spectrum. I'd either go extremely tunnel vision and I would just focus on the foot and ankle. And I got really good at making the foot and ankle function, but it didn't always carry over to whatever that big picture task they were trying to do. So then I had kind of a whole shift in paradigm where I went very holistic and I took a whole body approach. And with that, we potentially maybe got into these big gross motor movements, these more sport-specific movements, before we actually address some of those underlying more foot and ankle kind of tunnel vision site-specific deficits. So you've been in clinical practice now for several months with us. I'm sure you've gone through some ankle sprains at some point in your soccer career, but when you see ankle sprains and notably chronic ankle instability in the future, what are just some non-negotiables from an evaluation standpoint that you would like to do? And then what do you think are just some easy kind of big picture treatment ideas to go with?
Yeah, so I think when you think about ankle sprains and think about the population that we predominantly see, people do a really good job of kind of staying away from what hurts. So the body does a good job of telling you to stay away from things. So I think reading this article kind of clued me in that it's okay to get really specific when looking at the ankle to start off with, and then take a more global approach. So certain things like looking more into like a feed-forward approach rather than a feedback. So kind of force them to use that ankle and foot rather than just adding perturbations and trying to make them keep balance, right? If you're adding perturbations to someone trying to make them keep balance, what this article is telling us that people do a really good job at using their hip strategy, using their spine strategy, rather than tapping into some of their ankle strategies. A lot of proprioceptive work would be very helpful for this population. And then just also your strengthening of the muscles, adding mobility to the muscles as well.
Perfect. What are just some different potentially objective checkpoints or criteria that we can use from a balance standpoint or from a strength standpoint to let us know, and it's not going to give us an all-inclusive picture, but how do we know we're moving in the right direction with some of these individuals, either day one that we're assessing or just as we're going through their program, to actually know, hey, we are utilizing the foot and ankle complex in the manner we need to from either a balance or a strength standpoint?
Yeah, so one thing I didn't talk about here, but the study also looked at how these individuals respond to the STAR excursion balance test. So I think using the STAR excursion balance test to help assess their balance and what strategy they're using. STAR excursion balance, you can really see whether you're using a hip dominant strategy or whether you're using more of a knee dominant, whether you're using more of their ankle or not. Also, other stuff you could look at is your different range of motion testing, your strength testing, and then your single and balance testing day one, and then continuing to kind of recheck what their strength is like, what their range of motion is like, and how their balance is.
Yeah, and I think a lot of the just standardized tests that we have, either for mobility or for strength or for balance, they're good to get numbers on paper. They are good for consistency from a test, retest standpoint. I think one thing that we often overlook is a lot of qualities in those tests. And really, if you were just anybody without a PT background were to observe somebody doing some of those tests, you mentioned a STAR excursion test or maybe a Y balance test. It's a multi-planar, multi-joint, single leg squatting or reaching activity, essentially. That motion looks really similar to just different squatting and lunging variations that we're doing. So I think oftentimes if we just familiarize ourselves with various single leg strength, various single leg stability activities, it builds out our exercise programming very, very well for us. And then I think that's where our clinical expertise and just our judgment comes in. As a profession, we view ourselves oftentimes, the term movement experts often comes up. I think that should be our wheelhouse then. We should be very good at identifying what are appropriate exercises to do, and oftentimes the test for these individuals is can they complete that exercise? And I think this is where you can get into a lot of fun of if we know that they maybe preferentially use a hip righting strategy or more proximal musculature, let's put them in an exercise where we can constrain the environment so that they cannot do that. And I think there are different ways that we can continue to work, continue to train this athlete, and get a good physical conditioning component to it as we're sneaking in some of our movement competency tasks with them as well. So moving forward, is there anything within this article that really reshapes something that you'll do moving forward, or did it highlight anything that you feel like you should be spending more more time on in the clinic?
Yeah, I think you mentioned it, right? Just using a lot of those balanced interventions that we use, trying to use more of a constraint, right? So trying to, instead of just kind of seeing how they do with these balance activities, put them to positions where they kind of have to use that ankle strategy. And then from an evaluative standpoint, being a bit more precise when looking at what strategy they're using. So not just does it look good, but also does it look good and what are they using to accomplish that balance task, right? What are they using to do some of these functional tasks? Like we said before, right? These patients could do a good job kind of hiding some other problems down the chain. So really just focusing in on what strategy they're using, how does it look, and trying to get some type of quantifiable number on paper so you can always go back to look at that.
And I think something that gets underutilized in the clinic is the concept of adding cognitive demands or just dual tasking in general. And I think it can be easier for a patient to do something the quote-unquote right way if they're actively, consciously thinking about it and devoting all of their attention to moving in the most perfect manner. But unfortunately, when we're on the field or the court, we have to get a job done. We have to get a task done. So we can't always think about how am I placing my foot? How am I orienting my body? It's more, how do I get in front of this offensive player? How do I get around this defender? How do I get to the ball? How do I get to a spot on the field? So I think we need to mimic some of those demands in the PT environment, and we can do that early on with low intensity, either visual or cognitive demands during proprioceptive tasks. We can also do that later on by adding some more reactive components as well and seeing, is there a shift in strategy when we add layers of complexity? And then the last thing I would add is we are not always fully 100% fresh on the field, and we're going to be playing under fatigue. And playing in the second half or the fourth quarter is much different than playing at the opening tip or the opening kickoff. So making sure that we are also challenging these individuals physically in the clinic and making sure that there is not any change in strategy, performance, or tolerance under various levels of fatigue. So, Bami, thank you for selecting this article. I think it helps to just organize everybody's thoughts. For those listening, hopefully you got some take-home messages for this as to how you can implement it into your clinical practice. And stay tuned next month for when we get into the hip as our theme for the month.
Thank you.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.